welcome to the Hospital Medicine Unplugged podcast.
Great to be here. Today we're tackling a really high-stakes topic, pericardial effusion in the hospital setting. How we diagnose it, how we manage it now, synthesizing all the latest evidence.
Exactly, and our focus really is getting straight to what you need to do clinically. We're leaning heavily on the new 2025 American College of Cardiology consensus statements, because when you've got that patient, maybe with a big effusion, maybe deteriorating fast, you're under the gun. Decisions have to be quick, evidence-based, and risk stratified.
That really is the core challenge for any hospitalist, isn't it? Pericardial effusion boils down to risk stratification. You have to figure out almost instantly, is this just some benign incidental finding we can watch? Or is this effusion actively progressing towards, life-threatening cardiac tamponade?
Yeah, the stakes couldn't be higher. Get it wrong one way, you do an unnecessary procedure. Get it wrong the other way, well, that could be catastrophic.
And that's why we're grounding this deep dive in solid sources. The ACC expert consensus, plus key reviews from top journals like JAMA and the NEJM. We want to understand the why behind the guidelines.
Okay, so maybe let's lay the groundwork first. Defining the problem, the pathophysiology. Understanding why the pressure builds up really dictates how urgently we need to act.
Sounds good.
So defining the challenge. A pericardial effusion. Basically, it's fluid building up in that pericardial space. Typically, we start calling it an effusion when it's more than about 50 milliliters. That's kind of the threshold where it moves from maybe physiologic to potentially pathologic, right? It can start impacting how the heart works.
Right. And the clinical spectrum is just huge. You might stumble upon a tiny, totally asymptomatic collection on a CT scan done for something else.
Happens all the time.
Yeah. Or at the other extreme, you have fulminant cardiac tamponade. The pressure is so high, the heart literally can't fill properly. It's a true emergency.
And here's what's really crucial. The absolute linchpin for managing these patients. It's the rate of fluid buildup, much more so than the total volume, right? That's something people sometimes miss if they haven't dealt with tamponade hemodynamics directly.
Absolutely. That's often a point of confusion. We've all seen patients who've slowly accumulated maybe 2 liters of fluid over months. The pericardium stretches, it complies, and they might feel perfectly fine.
Totally asymptomatic.
Then you contrast that with, say, a post-MI free wall rupture. Maybe only 150, 200 milliliters built up, but it happens in half an hour.
Right.
That rapid filling completely overwhelms the pericardium's ability to stretch. The pressure spikes catastrophically, and boom, you've got tamponade.
That concept of compliance, or lack thereof with rapid filling, is just central. The pressure volume curve starts flat, but once it hits that steep part, even tiny extra amounts of fluid cause huge pressure jumps.
Exactly. And mechanistically, what's driving it? Well, if it's fast, it's usually acute inflammation causing leaky vessels. Often there's an innate immune response, maybe involving the NLRP3 inflammasome. Or in more chronic situations, it could be impaired lymphatic drainage, which we see a lot with malignancy, for instance. It's that inability to handle the rapid pressure rise that defines the emergency.
Okay, so focusing on our hospitalized patients, we really need to nail down the high-yield causes. Because the underlying etiology just completely changes the game, the urgency, the management, the prognosis, everything.
Right. Let's start with infections. So in places like the US or Europe, viruses are really common culprits for acute pericarditis, which often comes with an effusion. Think Coxsackie virus, herpes viruses, adenovirus. Usually these lead to small or moderate effusions managed pretty straightforwardly with anti-inflammatories.
But we can't be myopic. Globally, and certainly in specific patient populations like the immunocompromised or those from endemic regions, tuberculosis is still the #1 infectious cause.
Huge point. You have to think about TB, especially if the effusion is large, chronic, or if the patient have those classic systemic symptoms, night sweats, weight loss. Missing TB is a major pitfall.
Definitely. And then you have the real septic nightmares, the purulent effusions, bacterial infections, often staph or pheas or strep. These are thankfully rare, but incredibly dangerous.
Extremely high mortality. They need immediate aggressive drainage and antibiotics. Not just because of the sepsis risk, but also because these purulent ones have the absolute highest risk of scarring down later into constrictive pericarditis.
Okay, moving on. Malignancy. A huge category we see in the hospital. Most often it's metastatic disease, right? Lung cancer, breast cancer, hematologic stuff like lymphoma, leukemia, those are the big players.
Yeah, and malignant effusions often have telltale signs. They tend to be large. They're frequently hemorrhagic, meaning bloody when you drain them. And crucially, they almost always come back.
Right. Recurrence is the major management challenge there.
It is. If you drain a malignant effusion once, you basically have to plan for it recurring. That means thinking about repeat drains or maybe more definitive options like a pericardial window pretty early on.
Then there's the whole category of iatrogenic and inflammatory causes, things we see all the time on cardiac units, post-cardiac injury syndromes, after an MI, after cardiac surgery, the post-pericardiotomy syndrome, or even after procedures like catheter ablations.
Yep, very common. And don't forget the systemic autoimmune diseases, lupus, rheumatoid arthritis. They can cause significant inflammatory effusions too. It's often a sign the underlying disease is flaring up.
So treating the effusion means treating the underlying lupus or RA, usually with immunosuppression.
Exactly. And finally, the metabolic causes. Uremic pericarditis, you see this in patients with advanced chronic kidney disease, especially near or on dialysis. That needs a specific approach.
Which is?
Intensifying dialysis. That's the primary treatment, not usually drainage unless there's tamponade.
Got it. And the other classic metabolic one is severe hypothyroidism, myxedema.
Right. Those effusions can be huge, but they almost always accumulate super slowly. They're typically non-inflammatory, hemodynamically benign, and they just melt away with thyroid hormone replacement.
Okay, that's a great overview of the why. So that brings us to actually recognizing it. How does the patient present, and how do we start the diagnostic process, moving from the theory to the bedside?
Right. And as we said, a lot of chronic effusions, surprisingly, cause no symptoms at all. But when patients do have symptoms, they're often frustratingly nonspecific. Shortness of breath, dyspnea, that's very common.
Chest pain too, but it can vary. Sometimes it's sharp, pleuritic, worse with breathing or lying down. Other times it's just a dull ache or a feeling of fullness or pressure.
Exactly. Fatigue is common, cough, and sometimes, kind of confusingly, GI symptoms, nausea, maybe some vague abdominal discomfort.
And that abdominal discomfort can be a clue, right? It might actually be liver congestion from venous backup because the right heart pressures are high.
Precisely. Which makes the physical exam absolutely critical for gauging the hemodynamic impact. We're looking for signs that pressure is building up. So tachycardia, tachypnea, fast heart rate, fast breathing, those are common compensatory mechanisms.
Muffled or diminished heart sounds are classic.
Yeah.
You know, the fluid kind of insulates the heart. But honestly, that can be pretty subtle and hard to appreciate sometimes.
It can be. But the one sign that really points towards trouble, towards impaired filling, is jugular venous distension, JVD. If the right atrium can't fill properly because it's being squeezed, that pressure backs up right into the jugular veins. Seeing elevated JVD is a major warning sign.
Which leads us straight into recognizing the emergency. Cardiac tamponade. Just to redefine it clearly, that's when the pericardial pressure is so high that it critically impairs the heart's ability to fill, leading to reduced cardiac output. This is act now territory.
Absolutely. Now, everyone learns Beck's triad in medical school.
Hypotension, elevated JVD, muffled heart sounds.
Right. But here's the danger. If you're waiting for that full triad to appear in your typical hospitalized medical patient, especially someone with a subacute process, you might wait too long.
You're setting yourself up for failure, yeah.
Totally. In those subacute or chronic cases, the triad is often incomplete. The blood pressure might hold up until the patient suddenly crashes. Hypotension is often a late sign. The JVD is probably the most reliable part, but even that can be tricky to assess accurately sometimes.
So, if the classic triad is unreliable, what's the single most important physical exam finding we need to actively look for at the bedside to pick up tamponade physiology?
It has to be pulsus paradoxus.
The hemodynamic key.
Exactly. Pulsus paradoxus, that's an inspiratory drop in systolic blood pressure of more than 10 millimeters of mercury. What it signifies is this exaggerated interdependence between the right and left ventricles because they're trapped in this high-pressure sac.
Explain that mechanism again.
Sure. When you breathe in, normally venous return to the right heart increases slightly. But in tamponade, that increased volume pushes the interventricular septum over to the left. Because the whole heart volume is constrained, this dramatically reduces the left ventricle's ability to fill during inspiration. Less filling means less stroke volume, so the systolic pressure drops.
And that drop, that pulsus, is a direct reflection of how badly filling is compromised by the pressure. Measuring it takes a bit of care, though, right? You can't just rely on the automated cuff.
No, you really need to do it manually with a sigmomedometer. You inflate the cuff, then deflate it slowly. Note the pressure where you first hear carot cough sounds, but only during expiration. Then keep deflating until you hear the sounds throughout the whole respiratory cycle, both inspiration and expiration. The difference between those two pressures is the pulsus paradoxus.
Requires careful listening and taking your time, which ironically can be tough when you suspect tamponade.
True. Okay, so moving to diagnostics. What tests do we order? The ACC consensus is crystal clear here. The first-line imaging test, without question, is transthoracic echocardiography, TTE.
Yeah, it's the workhorse. It's usually readily available. You can often do it at the bedside with POCUS, and it gives you so much crucial information.
Absolutely. TTE confirms there's an effusion. It tells you how big it is, roughly. Is the fluid free-flowing, or is it loculated, stuck in pockets? And most importantly, it assesses the hemodynamic impact. We're looking for those classic echo signs of tamponade physiology.
Like chamber collapse.
Exactly. Like right atrial collapse, usually seen in late diastole or early systole, or right ventricular free wall collapse, typically in early diastole. Plus, you look for exaggerated respiratory variation in flow velocities across the mitral and tricuspid valves. Those are all strong indicators of high pressure and tamponade.
What about other imaging? When do we think about cardiac CT or MRI?
Those are really reserved for specific situations. Maybe the TTE images were technically difficult, poor quality, or if you strongly suspect something more complex is going on, like a very thick inflamed pericardium, maybe constrictive physiology, or perhaps a tumor or mass associated with the effusion that TTE couldn't visualize well, loculated effusions sometimes show up better too.
But the key point from the consensus is that CCT or CMR are not recommended for routine assessment of simple tamponade, right? TTE should give you the answer you need urgently.
Correct. TTE gives you the functional assessment quickly. CT and MRI are more for anatomic detail or characterizing the pericardium itself when needed later.
Okay, alongside the echo, what about labs?
You need a focused lab workup. Definitely get inflammatory markers, ESR and CRP. These are helpful not just initially, but also for tracking response if you start anti-inflammatory treatment.
Troponin too.
Yeah, check a troponin, especially if you suspect there might be associated myocarditis or muscle injury. Basic labs like a CBC, renal function, liver function are standard.
And you tailor based on suspicion. Right.
Exactly. If you're thinking metabolic, check a TSH for thyroid, kidney function for uremia. If there's any risk factor for TB exposure history, immunocompromise, from an endemic area, you absolutely need to pursue TB testing, PPD, or preferably an IGRA blood test.
Autoimmune workup, like ANA.
Only if the clinical suspicion is high. The guidelines caution against routine autoimmune testing because low-titer positive results like an ANA are really common and nonspecific. You don't want to chase those down with invasive tests unless the whole clinical picture fits an autoimmune disease. It's about targeted testing, not a shotgun approach.
Makes sense. Okay, so probably the biggest decision point is whether or not to stick a needle in there.
Yeah.
Pericardial fluid analysis.
Yeah.
When do we drain for diagnosis and what do we test for?
Right, and let's start with the overarching principle from the ACC again. For a stable patient with an effusion but no signs of tamponade, routine diagnostic pericardiocentesis is not recommended.
Why not? If there's fluid, why not find out what it is?
Because the procedure itself carries risks: bleeding, infection, hitting the heart muscle, arrhythmias. In a stable patient where the cause is likely viral or idiopathic, those risks generally outweigh the potential benefit of getting a specific diagnosis, which often doesn't change management anyway.
Okay, so that's a key point. Avoid unnecessary procedures. When is drainage indicated then?
Two main reasons. One, therapeutically, if the patient has cardiac tamponade, you drain it urgently to relieve the pressure. That's life-saving.
And diagnostically?
Diagnostically, you drain if you have a strong clinical suspicion for certain high-risk causes. Specifically, if you suspect a bacterial infection, a purulent effusion, or if you suspect tuberculosis, or if you suspect malignancy as the cause, those diagnoses drastically change management and prognosis, so you need the fluid.
What about a large effusion that's just there and you don't know why?
Yeah, an unexplained large chronic effusion, say persisting more than 3 months despite non-invasive workup, might be another indication. But even then, the decision is individualized. You weigh the risks versus the potential diagnostic yield. It's not automatic.
Okay, so let's say you do decide to drain, either for tamponade or high suspicion. What tests do you order on that pericardial fluid?
You need a comprehensive panel to hit the critical diagnoses. Definitely cell count with differential, protein level, glucose, LDH, Gram stain and bacterial cultures are essential. Acid-fast bacilli, AFB, smear and culture for TB.
Yeah.
And very importantly, cytology to look for cancer cells.
Now, you mentioned a key pitfall here earlier when we were prepping. Something about applying pleural fluid criteria.
Ah, yes. Critical point. Do not use Light's criteria, the criteria we use to classify pleural fluid as transudate versus exudate for pericardial fluid.
Why is that?
Because normal pericardial fluid is already an exudate by those criteria, it's naturally high in protein compared to serum. So if you apply Light's criteria, almost all pericardial effusions, even simple benign ones, will get labeled as exudates. That can mislead you into thinking it must be something serious like infection or cancer, potentially triggering more unnecessary tests or worry.
It's a fantastic clinical pearl. High protein in pericardial fluid doesn't automatically equal badness. What about the cytology for malignancy? How reliable is that?
It's okay, but the sensitivity is limited. It really depends on the type of cancer and how many cells actually shed into the fluid. So a negative cytology, meaning no cancer cells seen, absolutely does not rule out malignancy, especially if the patient has a known primary tumor elsewhere or the fluid looks bloody. You have to consider the whole picture, the clinical context, the appearance of the fluid, and especially if it recurs rapidly after drainage.
Okay, got it. So we've assessed the risk, we know when to sample the fluid. Now let's talk management strategies. And it seems like the big dividing line is stable versus unstable.
Right. Absolutely. Hemodynamic status is paramount. Then etiology, then chronicity. Those guide everything.
So let's start with the stable patient. No tamponade in. What's the approach?
If the effusion is small or maybe moderate, and the patient is stable and asymptomatic, the recommendation is generally watchful waiting. Observation with serial TTEs to make sure it's not getting bigger or developing hemodynamic consequences.
What about a large effusion but still asymptomatic and no tamponade signs on echo and initial workup is negative, so idiopathic?
This is where recent data has been interesting. Even for those large, asymptomatic, idiopathic effusions, cohort studies suggest that a strategy of watchful waiting is actually quite safe. The risk of these stable, non-inflammatory effusions suddenly progressing to tamponade seems to be pretty low, as long as inflammatory markers like CRP are normal and the patient feels well.
So we don't automatically drain large effusions just because they're large?
Not anymore, if they're truly asymptomatic, chronic, and idiopathic after a reasonable workup. Drainage might be considered if it persists for a very long time, say over 3 months, but the guidelines say this decision should be individualized. There's limited evidence to support routine drainage just for size alone in a stable patient. Observation is often preferred. Okay.
Now, what if the effusion is clearly related to acute pericarditis? The patient has chest pain, maybe a friction rub, ECG changes.
Then the management shifts immediately to treating the inflammation. This is where empiric anti-inflammatory therapy comes in, and the evidence strongly supports high-dose NSAIDs.
Like ibuprofen or aspirin, what kind of doses?
Yeah, typically high-dose ibuprofen, something like 600 to 800 milligrams 3 times a day. Or high-dose aspirin, maybe 650 to 1,000 milligrams 3 times a day. The choice might depend on other factors, like if the patient has coronary disease, aspirin might be favored.
And you combine that with colchicine.
Absolutely crucial. Colchicine needs to be added. The usual dose is 0.5 or 0.6 milligrams twice a day. Or if the patient weighs less than 70 kilos or has kidney issues, maybe just once a day.
And why is the colchicine so important? It's not just for symptoms, is it?
No, its main benefit is reducing the risk of the pericarditis coming back. Recurrence is a major problem after a first episode. Colchicine helps modulate that inflammatory response long term. The ACC recommends keeping it going for at least 3 months. You do have to watch for side effects, though, mainly diarrhea.
Right. Now, many of our hospitalized patients can't take high-dose NSAIDs. Maybe they have kidney failure, bad ulcers, or they're on anticoagulants. What about steroids?
Corticosteroids are really reserved as second or third line therapy. You use them only if the patient fails NSAIDs plus colchicine, or if they have absolute contraindications to NSAIDs.
Why the reluctance to use steroids?
Because while they work well initially for inflammation, they're associated with a much higher risk of recurrence when you try to taper them off. Patients can get stuck in this cycle of relapse and needing more steroids. So if you absolutely have to use them, the recommendation is to use the lowest effective dose for the shortest possible time and taper extremely slowly.
Okay, that covers the stable and pericarditis-associated effusions. Now, the emergency cardiac tamponade, what's the management?
Immediate intervention. Urgent pericardiocentesis is mandatory. This should not be delayed waiting for anything else if tamponade is clinically evident or strongly suspected.
Ideally under guidance.
Ideally, yes. Echo guidance is preferred to make it safer, minimizing the risk of hitting the heart or lung. But if the patient is crashing and burning and you know there's a big effusion, an emergency blind subsaphoid approach might be necessary, though riskier.
And this procedure is both therapeutic and diagnostic.
Exactly. It immediately relieves the pressure, improves cardiac output that's therapeutic, and you get the fluid to send for all those tests we discussed that's diagnostic.
What about stabilizing the patient while you're getting ready for the drain? Fluids.
Yes. Giving a cautious IV fluid bolus can sometimes help temporarily. It increases preload and might buy you a few minutes by boosting filling pressure slightly before the drain goes in, but it's a temporizing measure only.
Okay, now a really important point you raised earlier. Positive pressure ventilation. Why is that generally a bad idea in tamponade?
Because putting someone on BiPAP or intubating them increases the pressure inside their chest. That positive intrathoracic pressure gets transmitted to the right atrium and vena cava, which further decreases venous return to the heart.
Which is already compromised by the tamponade.
Exactly. So you can actually precipitate a sudden catastrophic drop in cardiac output and blood pressure. Positive pressure ventilation should generally be avoided in tamponade until after the pericardium is drained, unless it's absolutely essential for severe hypoxia, and even then, use extreme caution.
Critical point. All right, let's shift gears to managing those specific high-risk causes we identified earlier. They often require different strategies. Let's start with purulent pericardial effusion.
Right, the bacterial infection. This is a true surgical emergency, often needing more than just a needle drain. The mortality is very high if not managed aggressively.
Why isn't simple pericardiocentesis usually enough?
Because the pus is often thick, viscous, and loculated, stuck in pockets. A needle drain often can't get it all out. So these patients frequently require surgical drainage, like creating a pericardial window to allow for complete evacuation and continuous drainage.
And antibiotics, obviously.
Immediately. Broad-spectrum IV antibiotics started empirically, covering likely pathogens like staph or EAs and strep, then tailored once cultures come back. And because the risk of scarring down into constrictive pericarditis is so high with purulent effusions, some centers advocate for adjunctive therapies like daily intrapericardial saline washes, maybe even with low-dose fibrinolytics like TTA, flush through a drainage catheter to try and break down adhesions and prevent constriction. The evidence for this is limited, but it's sometimes considered given the high stakes.
Okay, next high-risk group, malignant effusions. We know they recur. How does that change management beyond the initial diagnostic therapeutic tap?
Since recurrence is the rule, simple repeat pericardiocentesis often isn't the best long-term strategy. The ACC consensus leans towards more definitive procedures earlier on.
Like what?
Like surgical creation of a pericardial window, which allows fluid to drain into the pleural space or peritoneum, or sometimes placing an indwelling pericardial catheter for extended drainage over days to weeks. These approaches have lower rates of needing repeat interventions compared to just tapping it again and again.
Especially important in a population that often has a limited prognosis anyway.
Exactly, and sometimes, particularly in that palliative setting, we consider intrapericardial sclerosing agents. Instilling something like bleomycin or even talc into the pericardial space after drainage can cause inflammation and scarring that obliterates the space, preventing fluid from reaccumulating.
Okay, what about uremic pericardial effusion? The one in kidney failure patients.
Totally different approach here. Because the underlying cause is the uremia itself, the primary treatment is not drainage. It's intensifying dialysis. More frequent or more efficient dialysis usually resolves the inflammation and the effusions.
So you only drain if?
Only if the effusion is huge and causing symptoms despite dialysis, or if the patient develops frank tamponade. But the first step is always optimizing dialysis. Interestingly, if you do need to drain, studies show percutaneous drainage is still quite feasible and safe, even if the fluid layer isn't massive.
Good to know. And lastly, postoperative effusions after cardiac surgery, the post-pericardiotomy syndrome.
Most of those are inflammatory and self-limited. They usually respond well to the standard anti-inflammatory treatment NSAIDs plus colchicine.
Drainage reserved for tamponade or severe symptoms.
Correct. And similar to malignant effusions, if it becomes recurrent or seems loculated on echo, a surgical window is often preferred over trying repeated needle aspirations.
It really underscores how etiology-specific the management becomes, which then leads into our final points: monitoring, complications, and prognosis. How do we follow these patients?
The cornerstone of monitoring is serial transthoracic echocardiography. TTE is your main tool.
How often?
It depends. For stable, smaller effusions being watched, the interval can be tailored maybe weekly initially in the hospital, then perhaps monthly as an outpatient looking for any change. But for large effusions or symptomatic ones or post-procedure monitoring, you need much closer follow-up.
Like daily echoes?
Often daily or at least every 1-2 days initially while they're hospitalized, because progression to tamponade can sometimes be unpredictable. And this has to be coupled with vigilant clinical monitoring, checking for symptoms, JVD changes, and specifically reassessing for pulsus paradoxus frequently.
We've talked about tamponade as the big acute complication. What about long-term issues?
The main long-term worry, especially after certain types of effusions, is constrictive pericarditis.
The pericardium scarring down and becoming rigid.
Exactly. It fiboses, sometimes calcifies, and basically encases the heart in a rigid shell, severely limiting diastolic filling. This is a particular risk after purulent effusions, the highest risk. Also, after uremic pericarditis, recurrent malignant effusions, or sometimes after radiation or surgery.
What clues should make you suspect constriction later on?
Patients develop signs of chronic right heart failure, persistently elevated JVD, often with a Kussmaul sign where the JVD actually rises when they breathe in, plus maybe ascites and peripheral edema. Echo will show characteristic signs like septal bounce and diastolic flattening. It's a tough diagnosis sometimes, requiring careful hemodynamic assessment.
And recurrence, as we've mentioned, is a major issue, especially for malignant and sometimes post-op cases.
Right, driving the need for those more definitive management strategies early.
So, wrapping up with prognosis, it sounds like it varies wildly depending on the cause.
Completely. For idiopathic or viral effusions, the prognosis is generally excellent. Most resolve spontaneously or with simple anti-inflammatory treatment. For uremic effusions, prognosis is also good if managed effectively with dialysis. The outcome is usually tied more to their underlying kidney disease.
But then there are the poor prognosis groups.
Yes. Malignant effusions, unfortunately, carry a very poor prognosis. Survival is dictated by the underlying cancer, but median survival after drainage is often measured in months, typically around 5 to 7 months.
Grim.
And purulent effusions, as we said, have very high short-term mortality due to sepsis risk, plus that long-term risk of constriction. They demand the most aggressive, urgent management.
So if we had to synthesize the core message from the ACC consensus, what would it be?
I think it's that effective, safe management hinges entirely on a risk-stratified approach.
Yeah.
You must determine the likely etiology, and you must rigorously assess the hemodynamic impact.
And remember that hemodynamics means rate, not just volume.
Exactly. It's the rate of accumulation and the evidence of compromise on echo or like chamber collapse or pulsus paradoxus that dictates urgency, far more than just the absolute size of the effusion on a static image.
Right.
You treat the physiology and the underlying cause, not just the fluid itself.
Which brings us perfectly to our final provocative thought for you, the listener, the hospital clinician. We've heard about the relative safety of just watching chronic, asymptomatic, idiopathic effusions. We also know that pericardiocentesis, while sometimes necessary, isn't risk-free. You can cause bleeding, puncture things. So the question is, how aggressively should you pursue a specific diagnosis by draining the fluid when all the major red flags, fever, recent trauma, known cancer, signs of a specific systemic illness are absent, and the echo shows absolutely no hint of tamponade physiology?
It really challenges our reflex to always find an answer. The guidelines seem to be pushing towards more diagnostic restraint in these low-risk scenarios. If the patient is stable, the high-risk causes seem unlikely. Maybe the best and safest course is sometimes just vigilant, non-invasive monitoring and trusting time. It takes clinical courage to not intervene sometimes.